Hi, everyone. Good evening if you're in Central Europe like me, or otherwise good morning or good afternoon. My name is Bada Yang. I'm a medical doctor and I'm a PhD candidate at the University of Amsterdam, Amsterdam UMC, Department of Epidemiology and Data Science. And as you all know, we'll be talking about QUADAS-C. That's the new risk of bias tool for assessing comparative diagnostic accuracy studies. QUADAS-C is also an extension to the widely used QUADAS-2 risk of bias tool. That's for diagnostic accuracy studies in general. For this talk, I would also like to acknowledge other investigators in the QUADAS-C group, Susan Mallet, Yimsi Tekwangi, Claire Davenport, Christopher Hai, Penny Whiting, John Deeks, Mariska Leeflang, and others in the QUADAS-C advisor group as well. So first of all, I have no conflicts of interest to declare. By the way, if you cannot hear my microphone correctly, please let me know and I'll try to switch on to a different way. So for today's talk, I'll be talking about three things. One is, what are comparative accuracy questions? So this is more of an introduction to the field of comparative accuracy. Subsequently, we'll be talking about some frequently used study designs to answer comparative accuracy questions. And lastly, I'll be explaining about how we can assess risk of bias in these studies using QUADAS-C, how QUADAS-C was developed and how its structure is. And we'll be talking about a few items in QUADAS-C. So first, to get to know you a bit more better, I have a few questions in the first poll. The first is your experience with diagnostic accuracy reviews or studies, and the second is about your experience with QUADAS-2. And I think we reached saturation. Yeah, I think you can see also the poll results. A minority of the people today authored a review or study in diagnostic accuracy and also has used QUADAS-2. I think the majority is not so familiar or familiar and have heard of it or not used QUADAS-2 yet. Okay, that gives me a good idea of the audience today. Thank you so much. So what I assumed for today's talk is quite basic. I think I assumed that you were familiar with systematic reviewing and how quality assessment normally goes in systematic reviews. I also assume that you're familiar with some measures of diagnostic accuracy, but we'll be only talking about sensitivity and specificity today. So let's talk about the first thing, and that is, what are comparative accuracy questions? So comparative accuracy is to some regarded as a kind of niche field of research, but I tend to disagree because a lot of questions that clinicians have is, how does one test accuracy compare with another? And actually, if you look at all of the diagnostic accuracy reviews in the Cochrane library, more than half of them actually have a comparative accuracy question. So let's assume that we have a patient who has severe abdominal pain and comes to the emergency room, and we suspect the patient has acute pancreatitis, which is a severe inflammation of the pancreas. Now, doctors routinely measure an enzyme called amylase in the blood to diagnose this condition. And let's suppose we want to know how accurate is amylase in diagnosing acute pancreatitis. Well, so how do we do that? Well, a simple design is to take patients who are suspected of acute pancreatitis, measure amylase in everyone, and give everyone a reference standard test. The reference standard test is the best way to determine whether someone actually has acute pancreatitis or not. And if we do that, we can cross-classify the results of amylase and the reference standard, AP here standing for acute pancreatitis. And we can then have 2x2 tables like this and calculate sensitivity and specificity or other measures of test accuracy. So these are just fictional numbers. Now, suppose that we don't only want to know the test accuracy for amylase, but also from lipase. And lipase is another enzyme that is frequently tested for the diagnosis of acute pancreatitis. And many clinicians think that lipase is more sensitive and more specific than amylase. So is lipase truly more accurate than amylase? How do we assess the relative accuracy of these two tests? We can also have a relatively straightforward design where all patients suspected of acute pancreatitis undergo amylase testing first, and then undergo lipase testing after that, and also undergo the reference standard test. So they undergo 3 tests. And if we do that, we can then calculate accuracy measures for amylase and lipase. So then we have 2 2x2 tables. We can also have one very big table where we also have the cross classification between the results of amylase and lipase, that we also know the agreement between these 2 tests. But these numbers are sufficient for us to calculate relative accuracy measures. For an example of a relative accuracy measure is relative sensitivity, which is nothing else than just a ratio of the sensitivity of the amylase divided by the sensitivity of lipase. And these are some fictional numbers where you can see that amylase is here 1.33 times more sensitive than lipase. So a clinical question like this can also be put into a PICO-like framework. And then we can imagine that the population here is patients who are suspected of acute pancreatitis presenting to the emergency room. And then our intervention is our first index test, which is serum amylase. Index test B is serum lipase. Sometimes people call index test B a comparator test. I usually refrain from using the word comparator because some people think of the reference standard when they hear the word comparator. And the outcome that we want to measure is accuracy for acute pancreatitis, which is detected by the reference standard, which can be biopsy, surgery, or any other test for acute pancreatitis. So what I want to point out here is that the reference standard is not a comparison test, but is actually part of the outcome. The reference standard is here a means to determine which people have the target condition and which people don't. But the comparator here is actually lipase. This is, by the way, a clinical question addressed in Cochrane DTA systematic review by Rompianesi and colleagues. So why are comparative accuracy questions important? As you might know, most diagnostic accuracy studies, they estimate the accuracy of a single index test. However, this does not always translate easily to decision-making. That is because decision-making often involves the consideration of alternatives. And decision-making can therefore be benefited by the consideration of relative performance of competing tests or alternative tests. So comparative accuracy studies do exactly this by assessing multiple tests and comparing their accuracy. You can view comparative accuracy studies as kind of emulating randomized controlled trials of intervention that, or randomized controlled trials of diagnostic tests that look at the effect of diagnostic tests on patient-important outcomes. And you can then view test accuracy as a surrogate for patient-important outcomes. So just to also summarize the difference between a single test accuracy question and a comparative accuracy question, the question in single test accuracy is how accurate can an index test classify individuals with and without a disease? And we can use sensitivity and specificity or other test accuracy measures. And this is relevant for knowing the probability of the disease after you obtain a test result and to find a test's appropriate position in the diagnostic pathway. With comparative accuracy, however, we're looking forward to know how the accuracy of one test compares to the other. And we're then interested in absolute or relative differences in sensitivity and specificity or other test accuracy measures. And this is relevant for estimating the change in accuracy when an alternative test is used. and for informing decisions on which test to use for clinical practice. So far I've kind of introduced the field of comparative accuracy quite in a simple way. I'm now looking at Carol to see if there are any questions from the audience.
Hi. Hi, yeah, there was just a question about whether you were going to share your slides. I know we are doing a recording of this presentation, so we will be sharing the recording on our website and we'll email it out to you. But would you also be able to share your slides with the audience?
Absolutely, yeah.
Okay, wonderful.
I guess I can email that to you, Carol, or to someone.
Yeah, to Cyprian would be great.
Okay, yeah.
Okay, and maybe do we want to see if anybody wants to ask a question, just like through video right now?
If anyone has questions, please let me know. I'll pause for a few seconds.
Oh, there is one hand up.
Hello, sorry, I cannot unmute myself before.
Oh, okay.
Yeah, because of settings. Thank you so much for this lecture. I have a question that relates to my research. I'm doing systematic review now, and I'm doing it about validity and reliability. And I find out that some authors misunderstand validity and reliability, and because of that they use kappa statistics, and they know that kappa statistics is used to accuracy as well. And I would like to know if actually kappa statistics can be used in validity assessment of two diagnostic methods comparison, or what do you think about that? Because I find out like different information about that online, and not very strong statistical arguments for using kappa statistics in comparison of two different methods, because originally it was designed for comparison between two comparator, not methods.
I see. Thank you for your question, Olga. I'm not sure whether I'm the best person to answer this question. It seems to me a bit broader question than the field of comparative accuracy. My limited knowledge, I would say that kappa statistics or reliability is a little bit of a different domain than accuracy. I think accuracy, we're really talking about validity and criterion validity in particular. So we are then assuming there is one gold standard, or well, now we use the term reference standard to determine which person has and has not the target condition. And we basically say, well, a valid test is one that can pick out all the people with the target condition among them. And there are studies that, for example, some COVID studies, I believe, that say, well, there's no real good reference standard for COVID, and therefore I present kappa statistics instead of diagnostic accuracy measures. So then you're more looking at the agreement between an index test and the reference standard for COVID, rather than assuming, well, this is about validity. I guess it's two different ways of looking at the same issue, whether you recognize that whether you can talk about this issue in terms of validity, assuming that there is a really good reference standard available, or acknowledging that we're more looking at agreement rather than accuracy.
Okay, thank you so much. I just have a little bit different view of accuracy, and it's okay because it's so many definitions of it. Because I believe it's kind of mix of validity and reliability. Because negative predictive value, for example, we consider reliability measure, not validity. That's why actually, so this kappa statistics kind of hard to for me to understand if it's a good measure of validity or not. But thank you so much for explaining your point of view.
Thank you for the exchange. Again, I'm afraid I'm not the best person to give an answer to this question, but I enjoy. Thank you for the interaction. So staying in comparative accuracy, I would like to carry on describing some often used study designs for answering comparative accuracy questions. So first of all, this is how sadly, most frequent way of how test comparisons are done nowadays. Here we have two studies. Study one is evaluating lipase, study two is evaluating amylase, and they have different types of patients, as you can see. Also different reference standards. And I have a poll question for you. Now, this method of comparing tests is also called between study comparisons. And I would like to ask you, this method of comparing tests can be problematic because difference in the type of patients, different types of reference standard, different study designs, all of the above, or none of the above. So the majority thinks that all of the above apply, and I agree with this. So indeed, the problem here is, if we observe that lipase is more sensitive of a test than amylase, can we say that this is because of the difference in test type? Or is there another factor that's responsible for the difference? For example, the type of patient population can be a factor, different reference standard, or maybe even differences in how the studies are designed. So risk of bias can also be a factor here. We sometimes refer to these factors as confounders because these has parallels to causal inference. So we want to know whether the index test type is actually a causal factor affecting the accuracy of tests. So these between study comparisons, as you can see, are clearly flawed and does not result in reliable estimates of comparative accuracy. Now, the strongest evidence, however, comes from comparative accuracy studies where you have comparisons within a study. However, comparative accuracy study is not just one design. There are many different types of designs. So we have done a literature review where we look at the variation in comparative accuracy designs, and we also thought of a classification scheme based on this. And the following is based on this classification scheme. So the most robust comparative study designs are the ones that we call paired or randomized. The one you see on the left is quite straightforward. So we have a series of patients who undergo test A and then test B, and everyone receives the reference standards. So we call this a fully paired design. And the immediate appeal of this design is that the people who receive test A and people who receive test B are identical. So they're exchangeable and there cannot be confounding unless there is missing data. Another great advantage of this study design is that you can explore the accuracy of not only test A and B, but also the combinations between them. For example, parallel combinations where a positive test result is when either test is positive, or any kind of other serial combinations as well. A disadvantage of this design is, however, that tests can influence each other. For example, if both are blood tests and there's no enough blood sample left after a first index test, then this can have, then test B can be disadvantaged. Now, if index tests are interfering or influencing each other, this study design is not so well suited. Then we better randomize patients to one index test or the other by randomization. And if sample size is large, randomization will ensure that A and B groups will be comparable in terms of factors affecting test accuracy. Another advantage of randomized designs is that you can also assess the effects of the tests other than accuracy, such as direct harmful effects of the test, which, for example, is relevant if you have biopsy as a test, maybe. However, randomized designs or other unpaired designs typically have less power than paired designs. So these are two robust designs. On the other side of the spectrum, you have studies that are neither paired or randomized. So we call these unpaired, non-randomized designs. Easily, you can think of designs where clinicians decide who gets test A and who gets test B based on clinical indication. This will lead to confounding by indication. Or you can have designs where, for example, a hospital says in 2019, we're going to use test A, and from 1st of January 2020, we're going to use test B. So we don't have a guarantee that patients who get A and B are comparable. Thank you for your question, Nigar. There's a slot where I will answer questions that will come in a few minutes. So please save your questions for then. So some lesser known designs are comparative studies where some participants are paired. So this is a study where everyone gets test A, but only a random subset of them gets test B. We call this a partially paired study with a random subset. Now here, just like the randomized study design we've seen earlier, if the sample size is large, people getting test A and test B will be exchangeable because of randomization. However, we don't really know whether these studies designs actually exist. It's a more of an hypothetical design. We didn't really come across any such study designs. But you can have the same design, but then there's, instead of randomization, a different mechanism to allocate patients to test B or just a reference standard. We call this partially paired with a non-random subset. Now here, just like the unpaired non-randomized study, because there's no randomization, we cannot assume that people getting test A and people getting test B are comparable in terms of factors affecting test accuracy. Now, of course, if the proportion of patients who are paired is large enough, we can probably assume that the patient groups will be more comparable if the proportion of paired people are large. So I've illustrated some commonly used study designs for comparative test accuracy. Of course, the partially paired with random subset is more of a hypothetical design. I would just like to ask you whether you have any questions, and I see already hand raised from Nigar, if I pronounce your name correctly.
Yes, and there's also, sorry, there's also one question in the chat. So Nicola first,
okay.
though.
Yeah.
Okay, thank you. So my question is about the randomized versus pair design. So I just wanted to make sure I'm understanding correctly. So it's the advantages if there is any interference between the tests and if there's a harm that we can explore. But let's say we are just diagnosing acute appendicitis using ultrasound and CT. In this case, there is no interference between the tests. I'm just asking, maybe there is, I cannot see. And there is nothing that we can use randomization to explore the harm. The only harm is from the radiation or contrast, that randomization wouldn't make any difference. I don't know, I'm just asking.
Yeah.
Do you think the randomized version would provide any advantage?
Here, of course, I think it's best to ask a subject matter expert like a radiologist who will know best. With my limited medical knowledge, I would say a comparison between ultrasound and CT for appendicitis lends very well for a fully paired design. Unless there's a radiologist who, for example, says, well, no, patients undergoing both ultrasound and CT will experience so much fatigue that if they first undergo ultrasound and then CT, they would not be able to sit still because of fatigue or whatever. There could be some reasons that only the subject matter expert will know why or how there can be interference between these studies. Between the tests, sorry. To me, I don't immediately see a reason to resort to randomized designs in this case.
Thank you.
So, Bada, there is one question. What is the role for controlling for potential confounders in the neither pair nor randomized design?
Thank you for this question. Well, potentially a lot. There's a lot of role for controlling for potential confounding in designs that are unpaired and non-randomized. I think they should be controlled for confounding, ideally using a directed acyclic graph to identify potential confounders. However, in practice, when we look, we did a literature review of comparative accuracy studies. First of all, they're not very prevalent. Studies that are neither paired nor randomized are not very prevalent. But in our limited sample of those studies, none of them actually controlled for confounding. So it doesn't seem to be a very prevalent practice to control for confounding. Perhaps it's, I don't know why, maybe it's a lack of awareness because it's an accuracy study rather than an interventional study. But I surely think, if possible, we should try to control for confounding, for example, using multivariable analysis or any other conventional methods.
Last question in the chat. Olga, do you still have a question or has it been answered?
Yes. I wonder if you go into compare QUADAS with Cosmin tool. I know it's designed in the same university you're in, so you might be familiar. And if yes, like how are we different in assessment of bias? Because, for example, Prisma will soon develop recommendations for Cosmin, and like could we use this for QUADAS or not?
Thank you, Olga, for this question. Actually, we were different universities, but then we merged. So I recently got to know the colleagues over at the other university who were responsible for developing the Cosmin. So for me, Cosmin is a set of guidelines helping people to design better clinimetrical studies. So studies about measurement and different aspects of measurement. QUADAS, the QUADAS tools are really meant for only looking at one part of measurement, and that is diagnostic accuracy, or if you look at within the Cosmin framework, you would call that criterion validity. So it's much more limited to one type. And I believe I did see a risk of bias tool developed by the Cosmin group, but that was for reliability studies, I believe, not for studies assessing diagnostic accuracy or criterion validity.
They have for validity, but not for diagnostic validity. So maybe that's why.
Okay, yeah. In the third part, we'll be talking about QUADAS-C naturally. First, I will be talking about how the tool was developed, how it's structured, and we'll be going through a couple of items in QUADAS-C. So as many of you might know, there is already a risk of bias instrument for diagnostic accuracy studies, which is QUADAS-2. This is recommended by Cochrane and also implemented in Review Manager 5. And QUADAS-2, these are the questions in QUADAS-2. So you can see that there are four columns, which correspond to 4 domains: patient selection, index test, reference standard, and flow and timing. And for each domain, there are questions about risk of bias and questions about so-called concerns regarding applicability. Concerns regarding applicability is only relevant when you're doing a systematic review, because they ask, for example, whether the patients in the study correspond to the patients predefined by your review question. Now, so given the existence of QUADAS-2, you might wonder, why is a new risk of bias tool needed at all? Well, the thing is, QUADAS-2 deals with the risk of bias and applicability of a single index test, the accuracy estimate of a single index test, but does not address biases in comparisons between index tests. So we also did a literature search to answer the question, how do systematic reviews then assess risk of bias in comparisons of diagnostic tests? So we did a literature reviews looking at 238 systematic reviews that address test comparisons. And in each one of those 238, we looked at how do they actually perform risk of bias for the test comparison. So we found that of all these 338, only 2 of them assessed risk of bias in comparative accuracy studies for the test comparison in comparative accuracy studies. And the studies that in reviews that assess risk of bias, this was done using tools that were not designed for comparative accuracy studies. For example, there was a review that included only randomized comparative accuracy studies, and then they used the Cochrane risk of bias tool for randomized controlled trials, which is, I would say, not the worst. It's better than not having any form of risk of bias assessment at all. But the sources of bias are different compared to when we're looking at trials of interventions. So this demonstrates a clear need for a consensus-based tool for assessing risk of bias specifically for comparative accuracy studies. So we got together a team of experts in diagnostic test evaluation, the QUADAS-C group. On the left, you see the steering group, myself included. And the steering group organized most of the process of developing the tool and took the major decisions. And the advisory group, whose names you see on the right, were available for input and feedback and thinking along with the process. That happened about 3 years ago, establishing the group and thinking of a work plan. And the first study that we did was to examine how risk of bias assessment was done in existing systematic reviews. And then we together generated a list of potential sources of bias that could be relevant for comparative accuracy studies. And then a second study we did was looking at the variation and frequency of different comparative study designs. And then we did a so-called Delphi study. And then Delphi study is nothing more than a series of surveys after each other in order to come to a consensus on which items are important for QUADAS-C. And then we had a face-to-face meeting with the QUADAS group, and we did a pilot study among 44 participants to see whether what they thought of the QUADAS-C tool in its preliminary version. After that, we had a last round of revision and approval from the whole group, and now QUADAS-C manuscript is under submission at the journal. So this was the development process of QUADAS. I will just now talk about what do we mean when we talk about bias in the comparison of tests. And now I have a third poll for you regarding this. So the question is, if we're comparing 2 diagnostic tests and the accuracy estimates of each of these tests are both biased, is the comparison between them also biased? What do you think? Yeah, so the majority says yes, and about a third says it depends. I think I can actually go for either of those two. I would say, if I'm very simplistic, I would say yes. But like many things in epidemiology, a lot of things also depend. So thank you very much for answering this poll. I will elaborate on this in a short minute. So while we are conceptualizing bias in QUADAS-C, so what is comparison of accuracy? We were thinking of bias in 2 groups, basically. First, we were thinking of the one on the left, bias in at least one of the index tests being compared, which is captured by QUADAS-2, and also additional biases that are specific for test comparisons, which are not captured by QUADAS-2. I'll go over the green box first. So we think there is risk of bias in the comparison if at least one of the tests is at risk of bias. For example, there's a question in QUADAS-2 asking, was the index test interpreted without the knowledge of the results of the reference standard? So was the person interpreting the index test blinded to the results of the reference standard? Now, suppose that we're comparing 2 tests, A and B, and the answer for A is yes, and the answer for B is no, then it's pretty clear that the comparison between A and B may be biased because, well, test B is at risk of bias and will probably have an overestimated accuracy. But what if it's both tests are at risk of bias? Well, the comparison between A and B may still be biased because the magnitude and direction of the bias affecting each test may not be the same. Although in a rare case, it might be the case that the biases so-called cancel each other out. That would be the case if the direction of the bias and the magnitude of the bias will be identical for both A and B, but we think that might be a rare scenario. Therefore, the QUADAS-C group thinks for the comparison to be unbiased, each of the tests should be unbiased to begin with. And the second part is the blue box, additional biases that are specific for test comparison, not captured by QUADAS-2. So these are biases, for example, such as confounding, which do not play a role in the evaluation of a single test, but do play a role in the comparison. I will go through more of these biases in some of the next slides. So this is how the structure of these are the items in QUADAS-C. I'll run through each part of it with you slowly. So you can see that QUADAS-C has 4 identical domains, just like QUADAS-2 does: patient selection, index test, reference standard, and flow and timing. And it has signaling questions. So signaling questions are more factual questions in order to capture each aspect of the study design. And they can be answered yes, no, or unclear. And yes indicates low risk of bias, no indicates high risk of bias. And if there are 1 or more no questions answered, you may or may not judge high risk of bias based on your judgment, how severe you think the bias is. The risk of bias judgment is actually what matters the most. That's just one single question, which can be answered with low risk of bias, high risk of bias, or unclear. Now, you can see that each domain begins with the same question here. Was risk of bias for each index test judged low? That refers back to the risk of bias judgment in QUADAS-2. So this is the question that links QUADAS-2 with QUADAS-C. If the risk of bias was low in QUADAS-2, we answer yes, and that implies low risk of bias. I wouldn't be going over all of the signaling questions here because that would be too much, but there's one signaling question here: is undergoing one index test unlikely to affect the performance of the other index test? So this was the one index test interfering or influencing the other that we talked about previously. By the way, I didn't tell you this, but the signaling questions stated here are shortened. So we only see the shortened versions of this, otherwise it wouldn't fit in one slide. So the questions are a bit longer in the original version of the tool. So how can this be used with QUADAS-2? So this is how it should be used. So here we have one domain, patient selection. And you can see on top, here is QUADAS-2. So this is nothing new. And on the bottom, we have the new questions, the QUADAS-C questions. So you can see that QUADAS-2 is answered for each test individually, while QUADAS-C questions are answered for the test comparison. Now, you can also see that the first question here was the risk of bias for each index test judged low for this domain. This is the question that each QUADAS-C domain begins with. This is answered by using the question 1.4 in QUADAS-2. Could the selection of patients have introduced bias? If it is low risk of bias for both tests, then the question C1.1 can be answered with yes, which also implies low risk of bias when assessing risk of bias in QUADAS-C. So I've so far introduced you QUADAS-C and how it's structured and can be used together with QUADAS-2. And I'm also looking at Carol if there are any questions so far.
Hi, yeah, there is one question. It's what is the difference between QUADAS and the Newcastle Ottawa tool?
I see. I can see. Yeah. So Newcastle, Ottawa, to my knowledge, is to assess the risk of bias in observational studies. Also, observational study with a causal question, and that's probably that can be questions about exposures or questions about the effectiveness of interventions. And QUADAS is about the risk of bias in studies that assess the accuracy of diagnostic tests. I hope that makes it clear. Otherwise, please let me know.
Just to make sure, so we are just answering one question, but it's hidden in the three question, right? So in QUADAS-2, so we still need to ask was a consecutive sampling was done, case control and inappropriate exclusion. We still need to ask these questions in order to answer, could the selection of patients have introduced bias? Am I right? So
yes.
No.
Yes, thank you for this question. This was probably not something that I was very clear on this. So QUADAS-C is an extension to QUADAS-2, meaning that you first need to complete all the questions in QUADAS-2, indeed, such as the question 1.1 regarding consecutive sampling. And with that, you can answer question 1.4 in QUADAS. And question 1.4 in QUADAS-2 is needed to be answered in order to answer the first question in QUADAS-C. That is correct.
Olga has a question.
Thank you.
Yeah.
I'm wondering how you define diagnostic test. Do you mean just a laboratory test or, for example, questionnaires as well?
Yeah, that's a good question. With diagnostic tests, we are a bit broad. So yes, it can be a laboratory test, a questionnaire. It can be a physical examination, for example. It can be a pathological examination. So we define it quite broad. In essence, we mean either a non-dichotomous or dichotomous test in order to rule in or rule out the presence of a target condition. That would be a diagnostic test. And in the context of using this tool, it can also be a combination of tests. So we call those composite tests. So for example, ultrasound combined with CT, and there is a way to define test positivity of the combination. For example, either test is positive. You can also use that as a single diagnostic. You can also see that as a single diagnostic test.
Mm-hmm. In this case, do you implement something for questionnaires, because obviously they introduce more bias to the study than laboratory test?
I'm actually not too much of an expertise on questionnaires, but there might be indeed tests for which slightly different biases apply or additional biases apply. QUADAS-C is designed as a more of one size fits all for many different types of diagnostic tests, and we always do recommend tailoring the tool before using it in a systematic review to see whether additional signaling questions need to be added or whether some questions are irrelevant and needs to be omitted and so forth. Tailoring tool to the particular review question is still needed.
Thank you.
I will be just touching on a couple of sources of bias that are covered by QUADAS-C. There are too many to cover all of them, but I will just cover one from each domain. For example, for patient selection domain, one source of bias is when the index test groups are not comparable with regards to factors affecting test accuracy. We also call this confounding. Now we have covered this discussing study designs. To produce comparable groups, we need either each patient to receive all index tests in a fully paired design, or we need to randomly allocate patients to index tests, which can be done in an unpaired randomized design or in a partially paired random subset design. Now, if there is randomization, we of course need to look at whether the allocation sequence was truly randomly generated and whether the allocation was concealed until patients were enrolled and randomized to allocated to index test groups. And if neither design is used, there is typically no guarantee that the groups are comparable, and you're likely to end up with a high risk of bias judgment for this domain. just a simple example. This is a study from 1988 about the accuracy of two needles. One is called the true cut needle and the other is called the Mangini needle for the diagnosis of liver cirrhosis. Now, they say that in this study, more than 1,100 consecutive patients were randomized to one needle or the other. And they say that randomization was achieved by changing the type of needle at the beginning of each month. Now, there is a fourth poll question for you. Do you think the allocation sequence were random or the allocation and the allocation was concealed, or both, or neither? Okay, we have a majority saying neither and a third saying the allocation sequence was random. Thank you very much for answering this. My take on this is I would choose for neither, because they say the randomization was achieved by changing the type of needle at the beginning of each month. So that sounds to me like alternation rather than randomization. So it's not the allocation sequence is not really random, it's alternating. And since this is alternating, it's also predictable what the allocation sequence is, because I assume the doctors in the study know that after each month there is a different needle used. So this allocation sequence was also not concealed. So no random sequence generation, no allocation concealment. So carrying forward, I'll be talking about one bias in the index test domain, that is, were the index test results interpreted without knowledge of the results of the other tests? So then we're talking about lack of blinding, and that is the index tests were interpreted unblinded from the results of the other index tests. Now there's an example study here, and this study compares two cystoscopy techniques for the diagnosis of bladder cancer. And one is called white light cystoscopy, and the other is called narrowband imaging. Now, narrowband imaging, or NBI, is just using a different spectrum of light in the hopes of seeing the tumor better than just white light. Now, in this study design, all patients underwent both tests, so it was a fully paired design, and always first the white light and then the narrowband imaging. And the same physician performed both tests, and how they did it was they first used the cystoscopy with a white light, and after that they pressed a button and then the light color would change. And then they went over the bladder wall again to see whether there was a tumor. Now, it's not very hard to see why there's a risk of bias here, because when performing the second test, the narrowband imaging, the clinician performing the test would obviously know which tumors were found during scanning with the white light. So he cannot really forget what tumor he had just seen. So the study reports that NBI detected more tumors than the white light imaging, but the question is, was it really due to the index test type? In the reference standard domain, we have a question saying, did the reference standard avoid incorporating any of the index tests? And this incorporating alludes to what we call incorporation bias. And that is that one test is being part of the reference standard. Now, if index test is part of the reference standard, typically the agreement between that test and the reference standard will increase, leading to bias. Now, if one test is part of the reference standard and the other isn't, it's a clear case of bias, risk of bias. But even when both index tests are incorporated, there can still be risk of bias because the weight or the degree to which each test is part of the reference standard might not be the same. For example, there's a study comparing two questionnaires for the detection of dementia. One is called MMSE and the other is called GP-COG. And the reference standard was CAM-COG criteria, and it appeared that MMSE is a subtest within the wider CAM-COG criteria. So MMSE was actually part of the reference standard. Now, for the interest of time, I don't think I have time to go over the last one, which is about an appropriate interval between the index tests. but this comes down to the fact that the period between the index tests should be as short as possible in order to avoid things like disease progression, treatment in the meanwhile, or new disease appearing. So this is how QUADAS judgments are typically displayed, and mostly we think that people, when doing comparative accuracy reviews, you would like to display both QUADAS-2 and QUADAS-C results simultaneously. So here you see on the left side, the QUADAS-2 results for each index test. So that's CT and MRI. CRA stands for concerns regarding applicability, also coming from QUADAS-2. And the QUADAS-C results are displayed for the comparison between them. You can also display QUADAS-C results next to a forest plot, which will aid the interpretation of the forest plot naturally. There are also other ways of illustrating these results, which you can find in the guidance document of QUADAS-2, which will be QUADAS-C, which will be published, I think, within a month. Just one caveat, and that is that QUADAS-C is primarily designed for fully paired and randomized studies. That means that if you're assessing other types of designs, you might need to tailor the tool to capture other biases in more detail. And one last comment is that QUADAS-C does not assess concerns regarding applicability, as you might have noticed. That's because that is already captured in QUADAS-2. And we think if there is already an applicability concern in one of the tests, there must also be applicability concerns in the comparison. That's why we found it redundant to also have applicability questions in QUADAS-C. So this is my last slide. We developed QUADAS-C using rigorous consensus-based method with external feedback. QUADAS-C may be useful for systematic reviews and those designing and reporting comparative accuracy studies. And there are still challenges when assessing comparisons more than 3 tests. It's now mostly designed for assessing 2 tests, and also when assessing other designs in fully paired and randomized studies. Also, so far, QUADAS-C is made mostly with theoretical considerations in mind, and studies confirming the empirical evidence of bias still need to take place in the future. Thank you very much for your attention. And if you want to see the preliminary version of QUADAS-C, which was open to pilot testing, you can Google QUADAS-C, and that's probably the first result in your Google search. Thank you very much.
Thank you so much. So we'll just take questions, and so you can put up your hand. But I just also wanted to mention that we'll have, after questions, we'll just have one quick poll. So if you could just stick around to do that, that would be wonderful. So we have a question from Nagar.
Yes, so just to make sure, QUADAS-C, can it be used for indirect evidence? So meaning we can use it if the same study reports ultrasound versus CT, for example, but if it is coming from different studies, we can still do the comparison. Can we use it?
That's a very good question. So the short answer is no. QUADAS-C is only intended for comparisons within studies. But comparisons between studies, so comparison between 2 different studies, each evaluating its own index test, we cannot use QUADAS-C for that, because that is mostly and that is not happening within a study. So it's not about study design, but it's more about the comparison happening at the level of the systematic review. So it might be captured, for example, by a grade, by the grade framework, but not with QUADAS-C.
Thank you.